Okay, so today we are going to talk about sexually transmitted infections, and inside that, mainly the syphilis. Other sexually transmitted infections are not that important for you. Syphilis is a prototype STI, so I'm giving a lot of time to discuss that. Okay, but in the beginning, let's introduce what is STI, uh, how common those STIs are, and what are the implications of STIs in our health. Now, sexually transmitted infection is also known as sexually transmitted disease, but these days we prefer the term STI or sexually transmitted infection. They are transmitted through sexual activity, and I'm going to classify them a bit later. One of the most neglected field in our healthcare system, especially in the developing countries, is STI, because even the people are having STI, they don't want to go to hospital. Okay, they want to hide it, and once the complication develop, then only they go there. It is a major cause of infertility in both females and males. Now, what are the consequences or implication of untreated STIs? One of the very important point is infertility. I've already talked about. Okay, now 20 to 40% of the male uh, with untreated chlamydia and gonorrhea come present to the hospital with infertility, and almost double than that, 55 to 85% of the female with untreated pelvic inflammatory disease, which is a type of sexually transmitted infection, result in infertility. That is a very important data. Another important consequence is ectopic pregnancy. Now, there is 7 to 10 times increased risk of ectopic pregnancy in female with a history of PID. Okay, so let me clarify this further. If salpingitis has occurred, okay, salpingitis is inflammation of the fallopian tube. Now, there is a very high chance of ectopic pregnancy. There is increased risk of cervical cancer because human papilloma virus infection is a type of STI which will cause cervical cancer. Okay, not all, but serotype 16 and 18 especially cause cervical cancer. Chronic abdominal pain occurs in female who had pelvic inflammatory disease before, and there is increased risk of hepatitis B and HIV transmission along with other type of sexually transmitted disease. You already know this fact. One sexually transmitted disease, if it is diagnosed in the patient, we think the same patient may be having other sexually transmitted infection as well, because the modality of transmission is the same. Okay, now let's classify these STIs. Now the STIs can be bacterial, can be viral, can be protozoal, can be fungal, and can be ectoparasite. So let's start from the bacterial one, just the name. Okay, name of the organism and the disease caused by them. Okay, this is a very important question for you. Now, see that among the bacterial STI, okay, syphilis caused by Treponema pallidum is the important one which we are going to talk in today's class. Okay, another is gonorrhea caused by Neisseria gonorrhoeae. Okay, then chlamydia, the name of the disease itself is chlamydia, caused by Chlamydia trachomatis. This is the organism. It's a type of atypical bacteria. Chancroid is the name of a disease, and the name of organism is Haemophilus ducreyi. It belongs to Haemophilus genus. Then Calimatobacterium granulomatis is the name of organism, also known as Klebsiella granulomatis. It causes a disease known as donovanosis or granuloma inguinale. Gardnerella vaginalis is the name of the organism which causes non-specific vaginosis. Okay, non-specific vaginosis, also known as Gardnerella associated vaginosis, and some others like Mycoplasma hominis and ureaplasma ureolyticum, they can cause non-specific urinary tract infection, or they can also lead to pelvic inflammatory disease. Okay, so they are some of the important bacteria which can cause STIs. Let's move on. What about the viruses now? Which viruses are important cause of STI? Herpes simplex virus, HSV, mainly HSV2, but HSV1 can also lead to STI. Okay, human papilloma virus or HPV, HPV, it's a important type of STI. We call that genital wart in the beginning, but that anogenital or genital wart can complicate into cervical cancer, especially if a serotype 16 and 18 has caused the infection. Hepatitis B virus is an example of STI because one of the modality of transmission is sexual contact. HIV, very important virus which comes under STI, and we have already studied this in detail in medicine. Cytomegalovirus is also one of the modalities sexual transmission, and molluscum contagiosum can be transmitted through the sexual way. Among the protozoal STI, Trichomonas vaginalis, okay, Trichomonas vaginalis here causes trichomonas vaginitis, especially in female, and there is a typical type of discharge occurring in female, and it's a itchy condition. Entaemba histolytica and Giardia lamblia. I like to speak a bit more here. These are the important protozoa which cause GI tract infection. Okay, GI tract infection. Entamoeba histolytica mainly causes dysentery, but it can cause diarrhea as well. Whereas Giardia lamblia causes watery diarrhea, and it also leads to chronic, okay, giardiasis, which mainly results in malabsorption. But very rarely they can be transmitted by sexual contact. Okay, they can be transmitted by sexual contact. Now, some fungi can also cause sexually transmitted diseases. One of the important example is Candida albicans, which leads to vulvovaginitis in case of female and balanitis in case of male. Vulvovaginitis in female and balanitis in case of male. Okay, ectoparasite like Sarcoptes scabi and Thyrus pubis. This PH is silent here. We pronounce it as Thyrus pubis. It is also known as pubic lice or crab lice. Now remember, some other lice can cause scalp infestation, but this crab lice causes infestation in the pubic hair. That's why it is known as pubic lice. And one of the modalities is sexual contact for its transmission. Scabies, which is caused by Sarcoptes scabi hominis. It's a type of ectoparasite, belongs to mite family. It is also transmitted by sexual contact, but not always. There are so many other modalities of transmission. One of them is only sexual contact. Now, with this background information, let's enter into the syphilis topic. Okay, this is a little bit longer one, so let me explain this nicely. Now, syphilis is an infectious venereal disease which is caused by the spirochete Treponema pallidum. We all know that. This Treponema pallidum is a type of bacteria, and it falls under spirochete family. So these spirochete have a special property. They are motile organisms. Okay, they can move. Syphilis is transmissible by sexual contact with infectious lesion. That means direct sexual contact with the infected person. From mother to fetus in utero, which is called vertical transmission. During the birth, via blood product transfusion, if that blood is not screened for syphilitic organism by VDRL test, who knows, that may be contaminated or infected. And occasionally it is entering into the body through breaks in the skin as well, especially when you are examining that lesion of syphilis. Let me take example immediately. In primary syphilis, there is a genital chancre formation. If you do not wear glove and directly examine that lesion with your bare hand, and if you have slight break or cut in your hand, that treponema pallidum may enter into the body through that cut area. Okay, same type of example I can give in secondary syphilis as well. Now, this syphilis has a vivid type of presentation. It has many different types of presentation. Okay, it will mimic many other infection and immune mediated process in the advanced stages. Because of this reason, Sir William Osler, who is known as father of clinical medicine, okay, we know him as a father of clinical medicine. He this is a very famous statement by Sir William Osler: the physician who knows syphilis knows medicine because of its diverse presentation, because almost whole body would be affected in advanced stages of syphilis. Now, what is the pathophysiology of syphilis? Let's talk about this. Now, this organism, Treponema pallidum, okay, it is a very fragile bacterium. Okay, it is a fragile bacterium about 6 to 15 micrometer long and 0.25 micrometer in diameter. So it's a very small, as it is shown by the diameter here, and it can be seen, okay, well by dark field microscopy only. It is invisible on light microscopy. So we usually go for dark field microscopy to visualize this. And under the dark field microscopy, it has wave-like movement, which is known as undulating movement. This is a very diagnostic point about Treponema pallidum. Because it is a very fragile bacteria, it can survive only briefly outside the body. So transmission almost always require direct contact with the infectious lesion. Now, we already talked about what is the most common modality of transmission. That is direct sexual contact with the infected person. This syphilis is divided or classified into 4 stages: primary, secondary, latent, and tertiary. Okay. Now, it can be either acquired or congenital. So these 4 stages are mainly seen in acquired syphilis. Congenital syphilis is classified into early manifestations and late manifestation. It is described in a bit different way. Now, let's talk about acquired syphilis in the beginning, and then I'll move on to the congenital syphilis. Now, in acquired syphilis, this Treponema pallidum rapidly penetrate the intact mucous membrane. Now, remember, I like to explain a bit more here. Through the intact mucous membrane, it can enter inside the body. But if these mucous membrane are already ulcerated, or if they are already inflamed, then this organism will enter even more easily. Okay, but at the same time, through the skin, if those skins are intact, if there is no abrasion, no erosion, no ulceration in the skin, probably it cannot penetrate inside. But with the dermal abrasion or abrasion on the skin, it can even enter inside from the skin area. This is very important point. Now, after it enters inside, it will enter the lymphatics and then reaches the blood. The incubation period of syphilis on average is about 3 weeks, but it can range from 10 to 90 days. So you can remember it average of 3 weeks incubation period, and I'm sure every student know what is incubation period, isn't it? It is the period that is counted from the entry of organism into the body till the appearance of sign and symptom. This is called incubation period. So in syphilis, it is on average 3 weeks. Now let's talk about some more important points here regarding the histopathological findings in syphilis. There is one important term which is known as end arteritis obliterans. End arteritis obliterans. Now, what's the meaning of that? The arteries, okay, which are called end arteries, they don't have any anastomosis or any branching there. Okay, if they are blocked, then they can cause ischemia directly. So that area will be inflamed, and the common inflammatory cells are chronic inflammatory cells like plasma cell, like lymphocytes and macrophages. Now the problem here is, because of this end arteritis, okay, that particular area will develop ischemia, and because of the ischemia, a lot of other complication can happen. Now I like to remind you quickly here, in cardiovascular syphilis, there is formation of aneurysm in ascending aorta. Okay, that aneurysm is caused by ischemia of that particular area. Now that area will be weaker and outpouch. That is called aneurysm. Okay, so this is how we correlate the things. This syphilis is an example of delayed type of hypersensitivity, that is type 4 hypersensitivity reaction. And we all know in type 4 hypersensitivity reaction, the T lymphocyte and macrophages play a big role. Okay, in this case they form gamma. These gamma are almost like, okay, almost like the same type of lesion which is seen in tuberculosis. Okay, remember in tuberculosis what we call that? Caseous granuloma. Okay, so the gamma and granuloma are almost similar type of structure, just the name is different. And these gamma are mainly seen in tertiary syphilis. Okay, tertiary syphilis is gammatosyphilis is the hallmark of tertiary syphilis. Now, another important point in pathophysiology, the host or the human being which is infected with syphilis forms a lot of treponemal antibody and non-specific reagin antibody. Treponemal antibody and non-specific reagin antibody. Now, why the term non-specific? Okay, because they can be produced in other type of infection as well. Okay, the perfect example is VDRL and RPR. They are non-specific antibody. They don't confirm the diagnosis of syphilis, but nevertheless they give us, okay, or they tell us syphilis may be a possibility here. Syphilis may be a strong possibility, and we'll confirm the diagnosis later by a specific treponemal antibody test. Okay, when we reach our investigation, we'll talk about that. Immunity to syphilis is incomplete, so a person who has syphilis one time before can again have it later on. Now, what are these gamma? Let's talk a little bit about them. These gamma are the hallmarks of tertiary syphilis. Okay, it is also known as gammatosyphilis, to be very precise. So let me underline it and then discuss. Okay, now see here, this is a gammatosyphilis, isn't it? This gammatosyphilis, the hallmarks points is gamma. These gamma are almost similar to the granuloma which we see in some other diseases. These gamma principally form in the liver, okay, in the bone, and in testes. These are the common site for gammatosyphilis, and histological examination shows macrophages and fibroblast as well as plasma cell. Is many times I've repeated that it's almost same as granuloma. This gamma may break down and form ulceration, okay, and in bone they may cause a lot of pain. Now, if we take a biopsy from this gamma, then these treponemes may be recovered, but that is quite rare. It's same like from the caseating necrosis material. Okay, we can recover Mycobacterium tuberculosis, but the chances is very rare. It's okay. So it is almost the same here. Now, what about the cardiovascular syphilis? Okay. Now see here. Let me erase this first. Okay, fine. Now the cardiovascular syphilis occurs at least 10 years after the primary infection, and the main pathology in cardiovascular syphilis are aneurysm formation, and this aneurysm formation occurs in ascending aorta, which I already discussed. Because this aneurysm may be very near to the aortic valve, as a result of this, aortic valve regurgitation or aortic valve insufficiency may also occur. Okay, so this happens in cardiovascular syphilis. Now, what happens in neurosyphilis? Let's talk about this now. This neurosyphilis has a multiple presentation. One of that is syphilitic meningitis. Okay, syphilitic meningitis is a bit similar to chronic meningitis. So this can be a differential diagnosis of tubercular meningitis. Okay, the finding may be similar. So it is an early type of manifestation in the course of syphilis, and the CSF shows high protein, low glucose. Look here, it is like a bacterial, high lymphocyte count. Okay, this is a bit of chronic now, because if it is an acute one, there should be more neutrophil, and the definitive diagnosis can be given by positive syphilis serology. Now, there are two types of serological tests in syphilis. One is non-specific treponemal antibody test, another is specific treponemal antibody test. Both can be done. Second variety of manifestation in case of neurosyphilis would be parenchymal neurosyphilis. Parenchymal neurosyphilis. So let's talk a little bit about this. The two important terms which comes under these headings are tabes dorsalis and general paresis of insane. So what is this? Tabes dorsalis first. Tabes dorsalis develops when posterior column and dorsal root of the spinal cord are damaged. Now please listen very carefully here. Okay, we are moving on to the neuroanatomy and a bit of neurophysiology. Now posterior column, also known as dorsal column tract. Now the function of these posterior column or dorsal column tracts are, it carries fine touch, it carries vibration, it carries pressure, okay, and it carries proprioception. All of those sensations are carried by posterior column tract. And dorsal root, they carry all other types of sensation, especially touch, pain, and temperature. So if these are damaged, the patient are having a lot of sensory problems. The patient probably have cannot feel the vibration properly. They cannot balance themselves, and they cannot even feel pain and temperature. This type of condition is known as tabes dorsalis, which is one of the complication, you can say, of neurosyphilis. Now, what is general paresis of the insane? Okay, let's talk about this. Now, general paresis of the insane, okay, let me explain this by underlining. Because of the damage to cortical region of the brain, okay, general paresis of the insane occur. It is almost similar to dementia. Now, dementia is loss of memory. So in general paresis of insane also, there is loss of memory, okay, there is impairment of the speech, there is personality change, okay, the person will become irritable, and there would be development of psychotic symptom. And because of this, the term is general paresis of the insane. But to be precise, it is because of the damage of cortical area of the brain. Now, another very important manifestation in neurosyphilis is Argyll-Robertson pupil. Okay, Argyll-Robertson pupil. So let's talk about it now. What do you mean by that? This Argyll-Robertson pupil One second, okay. The Argyll-Robertson pupil is the pupil that doesn't react to light but does constrict during accommodation. Now let me explain in other way. So to understand this, you need to know what is light reflex and what is accommodation reflex. Now light reflex means I will show a torch light in one eye of that patient, and I will see what is the pupillary reaction there. Because of the light, that pupil should constrict if it is normally happening. Okay, if nothing is wrong there, if nothing is destroyed there, if pupillary reflex is normal, then pupil should constrict when we show the light. Okay, then what is accommodation reflex then? Now accommodation means, for example, I am looking at a very far distance. Okay, now somebody asks me to look at very near distance now. So what changes occur inside the eyeball when I do that? That is called accommodation. So three things are occurring during this phase. Number one, okay, the eyeballs are converging. This is called medial convergence of the eyeball. This is very important point. The second point, the pupils are also getting narrowed down. Okay, meiosis is happening. And third point, the curvature of the lens is getting more thicker. In the beginning, the curvature of the lens is more thinner, or it is more elongated, I should say. But right now, they are getting more flatter. So these are the three things which occur in accommodation. Now let's come to the point. In Argyll-Robertson pupil, light reflex is absent, but accommodation reflex is present. And it is seen in or in connection with tabes dorsalis and general paresis. Means the same patient who is having tabes dorsalis or general paresis may also have Argyll-Robertson pupil. Now, what may be the problem here? Where is the defect? And the defect is thought to be in the bilateral damage of pretectal nuclei in the midbrain, because that is a crossing over site for the neurons. Okay, so let's move on. Now let me erase this first. Okay, okay, fine. Now let's talk about what is the age distribution of syphilis. This comes under epidemiology. What type of or what age group and what type of persons are getting syphilis disease? Now, being sexually transmitted disease, okay, the person who are in sexually active age group will get this infection. There's no doubt about it. Okay, but having said that, even the babies are getting the infection, and that is because of the vertical transmission. But the most common age group is 20 to 29 years of age, but it can occur in other age as well. Now, another important point, which I already told many times, if one sexually transmitted infection has occurred in a person, many other sexually transmitted infection can also occur. And the reason is the modality of transmission is the same. Okay, that is sexual contact. So same person may be having syphilis, same person may be having HIV as well as herpes virus infection. Now, what may be the reason for this? One is the common modality of transmission, that is sexual contact. The another one, once there is genital ulcer or break in the mucosa, there is easy entry of the microorganisms inside. This is a very important reason. The third point, the genital ulcers, they will attract the CD4 cells to the ulcer surface. Okay, and if CD4 cells are present there, remember the connection between CD4 cells and HIV. The HIV virus can enter inside very easily. Okay, so these are some of the important points. Now, Having discussed about a bit of epidemiology, let's start about the clinical features. Now, clinical features includes of history taking, that is symptoms, and physical examination, that is sign. So let's start with the history. Whenever you are suspecting a patient of sexually transmitted infection, obtain thorough sexual and social history, including the number of sexual partner, okay, use of condom or any other mode of contraception, history of STD or STI in the patient and their partner, intravenous drug abuse, which is one of the common modality, and exposure to blood products. This is not only for the syphilis, but for any other type of sexually transmitted infection. In children and infant, we always ask the uh, history about the mother, because they get syphilis from the mother. So we should take a detailed history regarding mother. Now, what are the clinical features of primary syphilis? This is the first stage of syphilis, so let's talk about it. After the incubation period is over, I already told you the average incubation period is 3 weeks. So after that, the person will develop the lesion of primary syphilis, and this lesion is developed on the genitalia. In case of male, mainly on the glans penis. In case of female, it is on the vulva or cervix. Okay, in male, glans penis, and in female, vulva or cervix. Now, around 10% of the syphilitic lesion are found in other area also. It depends on what is the modality of sexual contact. So they may be found on anal region, on the finger, even on the oropharynx, even on some other extragenital site, but that percentage is less. See there, in 90% of the time, genitalia is affected. In about 10% of the time, some other areas. Now, what is the hallmark of primary syphilis? That is chancre. The lesion is called chancre. Okay, please remember the spelling here. Remember the spelling. It is called a chancre. Okay, so let me highlight here. This chancre is a painless lesion. Though the ulcer is formed there, it doesn't have any pain, or it doesn't give rise to any pain. It is usually solitary or single. It is raised on the edge. During examination, it feels like a foam, ulcer, and it may have papule on the surface. At the same time, the inguinal lymph nodes are enlarged, okay, but they are also not painful. Both ulcer as well as those inguinal lymph nodes, both are not painful. This is a very, very important feature of primary syphilis. Okay, and the place where these chancre are formed, you have already, known. Glans penis in male and vulva or cervix in case of female. Now, what will happen to this chancre? Okay, a bit later on, this chancre will erode and form a deeper ulcer. Okay, and they usually heal within 4 to 8 weeks, even without therapy. With therapy, they may heal a little bit earlier, but even without therapy, they may heal in 4 to 8 weeks. Now look at this. Look at this picture here. Okay, this picture is showing the chancre. So this is the chancre of primary syphilis. Okay, this is another one. Okay, this is the external genitalia of a male, and this is the external genitalia in female. These are the chancre. This is the hallmark of primary syphilis. Now, one point I like to highlight here: when you are examining, please don't examine like this. Okay, you should wear gloves all the time. This examiner is wearing the glove, but I can't see this examiner is wearing the glove here. Okay, so this is quite hazardous, because if there is a break on our finger or skin, the organism may enter inside the body. Okay, so let's continue. We are talking about primary syphilis before the break. Now let's go on to talk about secondary syphilis. Now secondary syphilis occurs, okay, after 4 to 10 weeks of the primary chancre, and it is most florid or most advanced in 3 to 4 months after the initial infection. Now, during this stage, it is a generalized type of infection. It is not localized like primary syphilis. Okay, so the spirochete, they rapidly multiply and spread throughout the body. So there are a lot of signs and symptoms of secondary syphilis. One of that is diffuse mucocutaneous rash. Okay? Diffuse mucocutaneous rash in different part of the body. These rashes are non-pruritic and bilaterally symmetrical. So non-pruritic means they are not that itchy, and they are bilaterally symmetrical, means they are present on both sides of the body. Along with them, there is generalized lymphadenopathy, but this lymphadenopathy is also similar to primary syphilis, that is non-tender in nature. When we palpate, it doesn't cause any pain. Now, where are those rashes mainly present? They present in the palms and soles, which is a very, very typical feature of secondary syphilis. Okay, and these rashes are macular, they are discrete. Discrete means we can clearly see the border of these rashes. They are reddish brown in color, and the diameter is around 5 millimeter or even smaller. Now, these lesions contain a lot of tryponims in them. Okay, especially if they are wet, they are highly contagious. One of the important example of this wet mucus patch is called Condylomata lata, and this is present near the genital area or near the inner aspect of the thigh. And if we palpate these lesions without wearing proper gloves, then that person can have a high chance of getting infection. Okay? Now, another types of presentation in case of secondary syphilis is patchy alopecia and a condylomata lata, which I just talked about. Now, this alopecia is a loss of hair. Okay, alopecia, to be very precise, loss of hair from any part of the body, but in this case, the hair loss mainly occur from the skull and face. Even the eyebrows hair can be lost. Okay, now they have given an important term for this type of alopecia. It is called moth-eaten appearance because it is very, very patchy. It is distributed here and there. So moth-eaten type of alopecia is a feature of secondary syphilis. This can be asked as an MCQ question in the exam. Along with this feature, there is constitutional symptoms present in the patient like malaise, headache, anorexia, nausea, okay, pain inside the bone, and fatigability. Fever is not high grade, and there may be neck stiffness because a small number of patients may develop syphilitic meningitis in this phase. Though syphilitic meningitis is a part of neurosyphilis, but because secondary syphilis can cause generalized infection in the body, it may be a part of secondary syphilis as well. Now, other less common manifestations are GI involvement, hepatitis, nephropathy means involvement of the kidney, proctitis is involvement of the rectum, arthritis, inflammation of the joint, and optic neuritis is inflammation of optic nerve. So if you analyze, many parts of the bodies are affected. Okay, now let's see the picture here. Let's see the picture and try to know. See here, these are the generalized rashes present on the body, on the anterior side, even on the face. Look at the rashes here. Okay, on the arms, on the anterior surface of the body, and on the back side. These extensive rashes present on the body. Okay, now rashes are present on palms as well. Okay, these are the typical features of secondary syphilis. Now, these lesions are known as condylomata lata. These are present very near to the genital area, and they have extended up to the inner part of the thigh as well, are also around the anal region. They are wet patches, they are mucosal patches, okay, mainly mucosal patches, because the similar type of mucosal disease has extended on the skin, so we still consider them as a wet mucosal patches, and they are highly contagious. Okay, they contain numerous number of spirochete in them. Now, after dealing with secondary syphilis, let's talk about latent syphilis. Now, latent means hidden phase. So in this condition, probably the signs and symptoms are not there, but syphilitic organism may be, it is present inside the body, and it may be multiplying in a small number. Okay, so they are asymptomatic, but the disease is detected only by serologic test. Okay, so latent syphilis is divided into early latent and late latent phase. Now, early latent is the first year after the resolution of primary or secondary syphilis, and late latent phase is after that. And this late latent syphilis is not infectious because the number of pathogens are very, very limited. Now, another important stage of syphilis is the tertiary syphilis. Okay? Tertiary syphilis. So let's talk a bit about it. It mainly affects the cardiovascular system in 80 to 85%, and the central nervous system in 5 to 10%. Okay, we already talked about them before, so it will be a quick revision for you. And it takes many months to years after the development of, means it takes months to years after the secondary syphilis. Okay, in between there is latent syphilis, and then tertiary syphilis will be there. There are three general categories of tertiary syphilis, and they are gomatosyphilis, cardiovascular syphilis, and neurosyphilis. During pathophysiology, we have talked about them. So let's quickly list what are the common clinical feature in all of them together. So the manifestation in tertiary syphilis may be impaired balance, okay, impaired balance, paresthesia, incontinence, and impotence. Now, many of them are because of involvement of the dorsal column tract and involvement of the other sensory tract like a dorsal nerve root. Focal neurological findings are very common, like sensory neural hearing loss as well as vision loss. This is a very, very important finding. Because of the cortical involvement, there is dementia or memory loss. Because of the cardiovascular involvement, there is chest pain. Okay, there is back pain, there is stridor, and other related symptom of aortic aneurysm. All of these, back pain, stridor, are related to aortic aneurysm because this is a mass in that area. This mass may be giving pressure to the nearby structure. The lesion of gummatous tertiary syphilis usually develop within 3 to 10 years of the infection, and bones are the common area where gummatous syphilis occur, and there occurs severe deep boring type of pain inside the bone, and characteristically this pain is worse at the night time. So sometimes patient even cannot sleep properly with severe pain inside the bone. Now, other symptoms and sign of tertiary syphilis would be headache, dizziness, disturbance of the mood, stiffness of the neck, and blurring of the vision. These are either because of syphilitic meningitis or cortical involvement. As a result of spinal cord involvement, the patient may be having weakness and wasting of the shoulder girdle as well as arm muscle, and the same patient may be having incontinence and impotence. I'm sure students know the meaning of these terms. Incontinence means urine and stool cannot be held. Okay, the patient is having them without any control. That is incontinence. And impotence means unable to have sustained erection. Okay, which can lead to infertility. Now look at these lesions once again. See here, okay, these are the gummatous lesion. These are called gamma. Okay? They are on different parts of the body. Okay? Gummatous lesion. If we take biopsy from this gummatous lesion, it almost looks like granuloma, meaning there are multiple inflammatory cells, okay, like plasma cell, lymphocyte, and macrophages. Now, what about congenital syphilis? Now, congenital syphilis means the baby is having or getting syphilis from the mother. This is one of the example of vertical transmission. These treponemes, they can readily cross the placental barrier and infect the fetus. Okay? Now, so this type of transmission can occur in utero or at the time of birth. And if it occurs in utero, it can result in spontaneous abortion and stillbirth as well. Stillbirth means dead baby. At the time of birth, the baby is already dead. Now, congenital syphilis has two stages, early and late. Now, early congenital syphilis occur within the first 2 years of life, and late congenital syphilis occur after that. Now, what happens in early congenital syphilis? Snuffles is the most important clinical feature in early congenital syphilis. Look at the term snuffles. This snuffles means there is a mucopurulent rhinitis which is caused by involvement of the nasal mucosa. So mucopurulent discharge from the nose is called snuffles. And a lot of other symptoms and signs are similar to the secondary syphilis in early congenital syphilis. Having said that, the patient may be having Condylomata lata and different mucocutaneous rashes. Okay, let me check, maybe some students want to join here. Okay, fine, nobody. Now, what happens in late congenital syphilis? Okay, what happens in late congenital syphilis? Let's talk about it now. Now, there are a lot of typical clinical manifestation in late congenital syphilis, which are saddle nose. Okay, this saddle nose is the deformity which occurs because of destruction of the nasal septum. So in this case, okay, the dorsum of the nose is depressed. Savorcine is because of inflammation and bowing of the tibia. Okay, the tibia are bent. This is called savorcine. Cloton joint is the inflammation of the joint, especially the knee joint. In syphilis, we call it Cloton joint. Hutchinson's teeth, very, very typical feature. In this condition, the upper incisor teeth are widely spaced and they are notched. Okay, I've collected a few pictures. I will show you. Okay, let me finish this first. So in this condition, the upper incisor are widely spaced and notched. And then one more called mulberry molar. In this condition, the molar teeth have too many cusps. Okay, usually it has three cusps, but in this condition, mulberry molar has 4 or even 5 cusps. So let me show you the picture now. Look here very carefully. This is called Hutchinson's teeth. Look at the notching here. Okay, this is notching in the teeth. Mainly the upper incisors are affected, but here even the lower incisors, I can see the notching here. And there is a gap between the teeth. This is very typical of Hutchinson's teeth. More than the gap, the notching is important. This is, okay, saddle nose. See here, the nasal bridge is depressed, saddle nose. Okay, Savorcine, the tibia are bent. Savorcine, look at the X-ray here. It is clearly bent forward. Savorcine it is called. This is mulberry molar. Just count the number of cusp here. Okay, uh, see here, 1, 2, 3, 4. Okay, this is here 5. I can see. Okay, this is 1, 2, 3. Okay, 4, 5, 6, one more is here, the 7. So there are many cusp presents in this molar tooth, and this is the typical feature of a congenital syphilis. It's a late stage of congenital syphilis. Now, after doing this, let's talk about differential diagnosis. What type of other diseases we can be confused with syphilis? Now, syphilis has an extensive differential diagnosis because many organs of the body are involved. This is the reason. So many other sexually transmitted diseases can be considered as a differential diagnosis here, like chlamydia, like gonorrhea, like trichomoniasis, like bacterial vaginosis, and even HIV infection. And one very important point, it is a reportable disease. So when you start working, okay, anywhere, if you come across a case of syphilis and if you confirm the diagnosis, please report it to the hospital management first, and it is their job to report to the authority later on. Now, another important part of this lecture is investigation. Now, how are we confirming the diagnosis? Now, Treponema pallidum has a very important characteristic feature. It cannot be cultivated in vitro. Okay, means it cannot be cultivated in culture media. So, serologic testing is considered the standard method of detection for all stages of syphilis, even the primary, secondary, tertiary, or latent, all type of phases. Serologic testing is considered the to-go investigation. Okay, having said that, some other investigations can be done as well, like I should take a smear from the infected lesion in primary and secondary syphilis and observe the organism under dark field microscopy. That option is always there. Now let's talk in detail about this investigation. Now see here. Okay, now in suspected acquired syphilis, first we need to perform the non-treponemal serological screening test. Now the important example of non-treponemal test are VDRL and RPR. VDRL and RPR. Now you may be wondering why they are called non-treponemal test, and the reason is these antibody can be found in some other diseases apart from syphilis. That's why they are called non-treponemal screening test. So what about the sensitivity of this test? Now see here, sensitivity of the VDRL and RPR are estimated to be around 78 to 86%. Okay, for detection of primary syphilis, 100% for the detection of secondary syphilis. So this is a very useful test there, and 95 to 98% for the detection of tertiary syphilis. So these are good tests to have. And specificity also ranges from 85 to 99%. Now I'm not sure whether you know the meaning of sensitivity and specificity here, so let me quickly discuss that. Sensitivity means the percentage of true positive. What is the power of that test to pick true positive cases? This is called sensitivity. And specificity means detection of true negative cases. How many cases do not really have syphilis? This is called true negative percentage. Okay, so this is the meaning of sensitivity and specificity. Very, very important knowledge. Now, VDRL test results turn positive 1 to 2 weeks after the chancre formation, and the chancre is seen in primary syphilis. So you need to wait for 1 to 2 weeks for this test to become positive. Now, if you want to diagnose syphilis even before this time, then what is the investigation for you? Okay, that is dark field microscopy. That is the test. Now, these non-treponemal tests usually become non-reactive with time after the treatment. That's why they are very useful in screening, and sometimes this antibody can persist throughout the life as well, but in many of the cases they become decrease in the titer and they become non-reactive. Okay, so let me delete this first and then erase actually, then I'll go to the another slide. So the important type of non-treponemal test are VDRL and RPR. Now see here, what are the treponemal tests now? Okay, these are called treponemal test, a treponemal antibody test. These are called fluorescent treponemal antibody absorption test, which is known as FTA absorption in the short form, treponema pallidum heme agglutination assay, and treponema pallidum particle agglutination test. So these are the important terms for you, and please revise them many times until and unless you are quite sure about the name. The most important among them is FTA absorption test. Now, these tests are very specific. If they are positive, then 100% of the time, okay, we can say this case is syphilis. That's why these tests are very, very important. Now, the third one I already told you is a dark field microscopy. Now, dark field microscopy test can be done from the moist cutaneous patches in case of secondary syphilis, which is known as Condylomata lata, and from the chancre in case of primary syphilis, and then we look under the microscope. This is called dark field microscopy. Please do not use light microscopy for the visualization because we cannot see anything. Another is slit lamp examination of the eye, just to know interstitial keratitis in case of congenital syphilis. This is one of the tests which we can do in congenital syphilis, in not other type of cases. Now, what about the neurosyphilis? How to diagnose neurosyphilis now? Okay, let's talk about it. Now, the VDRL test can be done in CSF. This VDRL test is a screening test, and you have already done CSF analysis. That already given us the clue this may be a chronic type of meningitis. On top of that, if VDRL test is positive, then we can suspect even further, and the confirmation is done by the a true treponemal antibody test like FTA absorption test. And if FTA absorption test is negative, okay, see this carefully. If FTA absorption test is negative in the CSF, it will rule out neurosyphilis. That is the meaning of specific test. Now, what happens to CSF analysis here? The cell count is increased, the protein is increased, glucose will decrease, and those cells are mainly lymphocyte. The cells are mainly lymphocyte. Now, what are the imaging study we like to do in case of syphilis? So to answer this question, you need to remember what are the clinical feature, which part of the body would be affected, and the answer would be very easy. For example, if abdomen is affected, and if I want to check what is happening inside the abdomen, I'll go for CT scan or ultrasonography. If chest is affected, we can go for chest radiography or chest x-ray, isn't it? If bones are affected, I can go for x-ray of the bone. And angiography is one of the very special type of test here, because syphilis can lead to aneurysm formation, especially in ascending aorta. Okay, this is the most common site. But even in abdominal aorta, sometimes the aneurysm can happen. Okay, but there is one important difference between aneurysm caused by atherosclerosis and aneurysm caused by syphilis. Okay, that is, in atherosclerotic abdominal aneurysm, the site is usually inferior to the renal artery, whereas in syphilis it is superior to the renal artery. Okay, that's a small point. If you can remember, it would be good for you later on, that questions can be asked. Now we have come to the final part of the discussion, and that is the treatment part. Okay, now how a treatment of syphilis can be done. Now treatment can be again divided into symptomatic, supportive, as well as definitive. Okay, so let's talk about the definitive treatment here. This particular organism known as Treponema pallidum is still sensitive to penicillin. So penicillin is considered the drug of choice in the treatment of syphilis. But some people are sensitive to penicillin, or they are allergic to penicillin, and in those people doxycycline is a good alternative. Okay. Now according to the different stages of syphilis, we need to adjust the duration of the treatment. For example, in primary syphilis, probably one dose of benzathine penicillin may be enough. But in case of neurosyphilis, that is not enough. We need to give probably penicillin G, okay, 4 or 6 times a day for 14 days. So what I'm telling here is it depends on the stages of syphilis. Now see here, you can easily get the knowledge from this slide. Okay, so let me highlight this and show to you. In primary or secondary syphilis, look at the treatment, benzathine penicillin. Okay, this benzathine penicillin is a intramuscular penicillin. Just one dose is enough, just one dose. This secondary syphilis is affecting almost the whole body, but even after that, just one dose of benzathine penicillin in the dose of 2.4 million unit for adult is enough. So treatment is pretty simple here. Early latent syphilis, you can give benzathine penicillin again, okay, in the same dose, in a single dose, so same type of treatment. In late latent syphilis, okay, benzathine penicillin is given in a higher dose, or you can divide the dose. Okay, you can make that large dose into 3 doses and give intramuscular at 1 week interval. You can give that large dose at once, or divide that large dose into 3 doses and give at 1 week interval. This is the treatment of late latent syphilis. So what is then for neurosyphilis? Now see here, for neurosyphilis, we use penicillin G, which is given IV. The dose is 3 to 4 million units, and it is given every 4 hours. Okay, every 4 hours. So in 24 hours, we have to give 6 doses now, and the total duration is 10 to 14 days. Now you may be asking question to yourself, why penicillin G is given so frequently and at a so high dose for neurosyphilis? Many students know the answer, I'm sure about it. Because it has to penetrate the blood-brain barrier and it has to reach the central nervous system. And for that, we need higher dose and for a longer duration. Okay. Now let's move to the, let me erase this first. Okay. Now, what you will do if the person is allergic to penicillin? So the drug is doxycycline, and it is given for 28 days. Okay, for the treatment of latent syphilis. And similarly, for other stages of syphilis also, doxycycline can be given. Okay, if somebody is even sensitive to doxycycline, sometimes it happens. People may be sensitive to doxycycline effect. Azithromycin can also be tried. Now, the last part of today's class is Jaris-Horsheimer reaction. Now, let me explain this in a nice way. During the treatment of syphilis, this drug, okay, kill those pathogen. Now, after the pathogens are dead, so a lot of toxic substances from them will release outside, and that will cause extensive inflammation. Okay, because of this mechanism, Jarvis-Horsheimer reaction will occur. Now, what are the symptoms of this? The symptoms may include myalgia, fever, headache, tachycardia, and sometimes if the lesions are already there, they will flare up, they will become exacerbated. So if we analyze, they are not very serious problems, so they can be handled by symptomatic treatment. You don't need to stop the treatment here. These reactions can be handled by symptomatic treatment, like, okay, antipyretic drug if the fever is a bit higher, analgesic if the person is having pain, a bit more pain in some part of the body maybe, or accordingly the persons can be managed. So this is not a difficult thing. And one important point, you should not stop the treatment because of this reaction. Okay, now when this reaction commonly occurs, okay, after the antibiotic treatment is started, sometimes even after several hours, and it usually clears within 24 hours of the onset. We really do not know what is the exact mechanism of this reaction, okay, but probably this occurs because of some immunological reaction to the rupture of spirochete, and that is mentioned in different textbook. Okay, so this is the end of the topic. At the end, these are the questions. Okay, I would love to ask this question to the student, but we do not. How many minutes we have? 3 minutes. Okay, let us ask a few questions to the student. Okay, anyone can tell me what is Argyll Robertson pupil, guys? Yes.
Yes, sir.
Yes,
When
please.
when light reflects, the pupil will constrict. It will accommodate. It's okay in cranial artery palsy damage to cranial artery.
Okay, so
reactive.
Yeah, sure. Go on. Yes.
Reactive for light reflex and non-reactive for accommodation.
Very good.
Ulta.
Okay, so Kamran and Salahuddin, okay, they are speaking. So remember, in this is a very important question. Okay, so I cannot hear the answer from all the students because we have very limited amount of time now. So remember only two things here. In Argyll Robertson pupil, light reflex is absent and accommodation reflex is present. Okay, if the examiner want to ask you further question, okay, then be ready for the explanation. Otherwise, this is a very correct answer. Now, second question, which is important from today's class, list the tryponymal test for the diagnosis of syphilis. What are those non-tryponymal tests and what are those tryponymal tests? Yes, I want to hear some answer now.
Dark field microscopy, VDRL, RPR, and FDA absorption test.
Okay, so Amanullah has told, so those non-tryponymal antibody tests are VDRL and RPR. Just remember these two. These are called non-tryponymal antibody test. They are also known as non-specific test, but very sensitive one. And the specific tryponymal antibody test are FTA absorption test, okay, TPHA,
Yes.
Treponema pallidum heme agglutination test. And one more, if the examiner asks you, can you tell me any other test, then you can say dark field microscopy. Dark field microscopy as your third answer. So if you answer like this, okay, the examiner will be quite satisfied. So with this, let me stop here now.